el autor o la autora del vídeo, es muy importante tener en cuenta algunos criterios. Primero, valorar la técnica. ...188.
Conflictos de interés que no van a influir mucho en esto, pero obviamente esto es un simposio de Pierre Fabre. Y voy a empezar con esta imagen. Este es un paciente de los que vemos cada día. Y lo que podemos pensar con esta imagen es que esto es una queratosis actínica, inicialmente con esta escama blanca, una placa, una lesión característica en un paciente con un campo de cancerización evidente y antecedentes de cáncer cutáneo. Y vamos a volver a esto después, durante mi charla, porque esto podemos tratarlo de muchas maneras, con el chorrito de crioterapia, aplicando tratamientos tópicos, etcétera, etcétera. Pero ¿sabemos cuál es el diagnóstico en realidad de este tumor? Vamos a verlo. Vale. O en esta situación, ¿no? Estos son los pacientes que vemos cada día. Pacientes con muchas lesiones, campo de cancerización, y ahí, bueno, aplicamos tratamientos muchas veces empíricos o basados en nuestro conocimiento, en nuestra experiencia, y guiados por un diagnóstico, fundamentalmente, ¿no? Y este diagnóstico no se puede basar en la histología de cada una de estas lesiones. Esto no puede ser. Bueno, el concepto del campo de cancerización y de lo que es las queratosis actínicas y el carcinoma escamoso, bueno, tuvo una cierta discusión hace un tiempo sobre la terminología. Y se decía que las queratosis actínicas deberían llamarse, cuando son queratosis actínicas algo más evolucionadas, carcinomas cutáneos, porque comparten histológicamente y molecularmente las mismas vías de activación que los escamosos. Pero esto con el paciente no es práctico, decirle usted tiene muchos carcinomas cuando tratamos queratosis actínicas. Con lo cual la terminología vamos a mantenerla, yo pienso que es bueno, diferenciando queratosis actínicas de carcinomas, aunque podríamos discutir histológicamente en las vías de activación que comparten. Y lo que es importante también entender es que muchos de estos pacientes, los que estamos aquí, si tenemos actividades durante nuestra vida al sol, tenemos campo de cancerización. Si ahí tuviéramos un LCCT de nuestra piel, veríamos cómo está nuestra piel en realidad. Y compartimos muchas alteraciones a nivel molecular y genético de lo que es un campo de cancerización, con mayor o menor gravedad. Nos guiamos los médicos, los clínicos, los dermatólogos, o los médicos de primaria que ven pacientes también con estas situaciones, en unas características clínicas, ¿no? Si la lesión es más hiperqueratósica, si está más infiltrada, si es más extensa. Y esto se describió hace muchos años por Olsen, ¿no? Y en realidad, bueno, muchas veces la impresión clínica es un Olsen 1, 2 o 3 en función de lo que vemos. Y esto también se describió hace muchos años a nivel histológico en función del grado de atipia que encontrábamos en estas lesiones, marcando diferentes niveles o grados de atipia en toda la epidermis, ¿no? Desde las queratosis actínicas más incipientes, con menos atipia en estratos altos, a las que tienen toda la epidermis afectada por atipia. Y esto lo describieron también los alemanes de Robert y Huber hace muchos años. Pero veréis que no es tan fácil. Porque en realidad sabemos por varios estudios, y si contáramos lo que hacemos en nuestra práctica clínica, que metemos la pata en el 9 o incluso en el 30% de las actínicas, pensando que son actínicas, en realidad no lo son. Y son estos tumores que hemos tratado, que nos vienen tratados y que no responden al tratamiento, y al final alguien decide hacer una biopsia y acaban con estas cirugías que veíamos aquí. Esto sucede en la práctica clínica y nos voy a contar lo que sucede en el ámbito de la salud, con atención primaria, con los tratamientos que se realizan en muchos casos sin mucho conocimiento de lo que pasa. Pero es que además hay retos, porque la clasificación clínica resulta que no se correlaciona muy bien con la histología. Lo que pensamos que es una queratosis actínica más evolucionada muchas veces no lo es, mientras que algunas de estas lesiones aparentemente menos agresivas clínicamente, histológicamente lo son. Y vais a ver que esto es relevante, es un problema que debemos reconocer. Y finalmente deciros que los resultados de los ensayos clínicos pues no reproducen el mundo real. ¿Por qué? Porque muchas veces no incluyen, por ejemplo, lesiones en el dorso de las manos o en antebrazos porque responden peor. Sabemos muy bien por qué responden peor. Microambiente tumoral, una serie de cosas. Pero, por ejemplo, este es un ejemplo, ¿no? Seleccionan los pacientes mejores para obtener los resultados que permiten la certificación y la aprobación de sus innovaciones terapéuticas. Bueno. A nivel diagnóstico, todos ustedes lo saben, con un dermatoscopio mejoramos el diagnóstico, no tan solo de las actínicas, sino también del diagnóstico diferencial que puedan tener, y sabéis el patrón en fresa, que corresponde a estos campos de cancerización y que refleja la disqueratosis de los anejos, que condiciona estos puntos amarillentos blanquecinos que tenemos sobre un fondo eritematoso propio de una lesión inflamada. Describimos hace muchos años estos criterios, que son 4 puntitos blancos en el acrosiringio, que traducen una disqueratosis de este acrosiringio con polarización cruzada. Vemos 4 puntitos, y esto lo describimos hace muchos años en Barcelona, y es muy útil cuando tienes dudas con otros tumores, sobre todo cuando están pigmentados, por ejemplo, un léntigo maligno. Vale. Por ejemplo, en el dorso de esta mano, esto es una queratosis actínica. Bueno, estas imágenes, en este caso, en una lesión que está parcialmente pigmentada. Esto nos ayuda a diferenciar una enfermedad de Bowen, patrón completamente distinto, con estos vasos glomerulares en clústeres con algo de disqueratosis, o un carcinoma escamoso, bien diferenciado por la hiperkeratosis, con esta vascularización que veis aquí. El dermatoscopio, esto un poco hay que saber identificarlo. Un carcinoma escamoso bien diferenciado, con estas áreas blanquecinas en círculos, obviamente por la disqueratosis del carcinoma escamoso en estas áreas. Esto es un vaso celular, no es una actínica, no es un carcinoma escamoso, es un vaso celular por el patrón vascular. Y en ocasiones tenemos problemas. Esto es un problema. El cirujano plástico que viene a consultarnos por esto, y tú puedes quemarlo, a lo mejor quizás no. Porque fijaros la dermatoscopia de esta lesión pigmentada. Si eres muy bueno en dermatoscopia, seguramente dirás, es una queratosis actínica, pero cuidado, podemos equivocarnos porque esto podría ser un léntigo maligno, perfectamente, ¿no? O la combinación de cosas. Ahí el confocal es lo que nos ayuda más, ¿eh? Pero no todos tenéis un confocal, la mayoría no tenéis un confocal, con lo cual aquí hay que hacer una biopsia probablemente siempre, ¿no? Muy rápidamente, los modelos de progresión también nos explican cosas, y es que hay la vía clásica, que tú esperas que el tumor evolucione en varias etapas, pero también sabemos que hay una vía diferenciada que llamamos, que es que una lesión desde el principio se va a comportar de forma agresiva y va a evolucionar rápidamente sin tener etapas bien diferenciadas con Olsen 1, 2 o 3. Y esto es un problema. ¿Por qué? ¿Es un problema o es una ventaja? Porque nos ayuda a entender que tenemos que tratar el campo de cancerización en cualquier caso. También sabemos que histológicamente estos tumores no son siempre iguales. El grado de proliferación que tienen histológica y que no podemos ver con un dermatoscopio ni clínicamente, traduce más agresividad del tumor, menos respuesta a los tratamientos y más capacidad de progresión a un carcinoma escamoso. Pero esto es invisible a nuestros ojos, no lo vemos, y no necesariamente están las lesiones con mayor hiperkeratosis. Esto hace tiempo se describió y sabemos que es un factor limitante en nuestra práctica clínica cuando decidimos los tratamientos. De hecho, en este artículo de colaboración demostramos que el grado de proliferación histológica de estas lesiones y algo muy importante, si el paciente se queja de que es dolorosa, traduce en lesiones más agresivas y lesiones que no van a responder a los tratamientos tópicos o habitualmente en la consulta clínica. Cuidado con estas lesiones. Volvemos a uno de estos pacientes. Bueno, ¿pensáis que puede tener, con lo que os he contado, un carcinoma escamoso? Podría ser, ¿no? Podría ser perfectamente que aquí tengamos un carcinoma escamoso. Bueno, tenemos algunas herramientas que son muy interesantes por muchos motivos. Esto es in vivo, una imagen de la piel, que en blanco y negro, pero reconoceréis la epidermis, los queratinocitos, o sea, es fantástico, ¿vale? Y en 3D, es un tipo de microscopio que tenemos en el departamento y nos permite, bueno, hacer esta correlación con esta histología de la misma lesión, ¿vale?, de una queratosis actínica en cortes tridimensionales, y podemos evaluar un montón de cosas in vivo. ¿Y por qué es interesante? Porque nos permite comprender estas lesiones in vivo. No tenemos que biopsiarlas, podemos entender muchas cuestiones y podemos entender lo que sucede, por ejemplo, cuando las tratamos con un medicamento en un momento determinado. Bueno, os voy a enseñar algunas imágenes de esto, pero con esto estamos aprendiendo mucho en dermatología, porque nos permite correlacionar muchas de estas lesiones. Aquí veis una queratosis actínica proliferativa, con esta proliferación en la dermis, que es lo que os quería mostrar. Y esto tiene una gran correlación histológica. Por lo tanto, no es que no se pueda hacer, es que ustedes no lo tienen en su consulta, porque es caro. Este dispositivo es caro. Vamos a ver este paciente. Bueno, le aplicamos un LCOCT y ¿qué es lo que tenemos? Pues ya sabemos, tenemos una imagen que nos está diciendo cuidado con este tumor, seguramente lo voy a extirpar, porque es una de estas lesiones que no nos va a responder bien a un tratamiento tópico. Y esto hoy en día lo podemos hacer. También podemos analizar con inteligencias artificiales, con analíticas complejas, todas las células de lo que os mostraba, de esta biopsia virtual. Y esto lo estamos aplicando con algoritmos que nos permiten ser muy consistentes y reproducibles evaluando la tipia citológica. Esto es fantástico, os podéis imaginar, ¿no? Bueno, no voy a entretenerme mucho más. Deciros que los clínicos, cuando tenemos pacientes con esta situación, no podemos decir tiene queratosis actínicas, hay que evaluarlos correctamente, porque pueden ser más o menos extensas, pueden ser confluentes, pueden tener mayor o menor grado de inflamación. Hay una serie de características clínicas que decimos, bueno, es que tengo mucha experiencia y ya sé que este paciente tiene mucho campo de cancerización. Sí, pero ¿lo puedo evaluar? Pues sí. Y hace años inventamos con colegas de toda Europa lo que es la CASI. Lo que pasa es que la CASI no lo utiliza nadie, a lo mejor alguien aquí, porque necesita un poco más de tiempo, pero nos permite entender si el paciente mejora o no y dónde estamos. Y esto evalúa toda una serie de características para zona facial, craneofacial, que pensamos que estandarizan y son reproducibles, lo demostramos que es reproducible. Bueno, tenemos algunas apps, cuidado con las apps, pero esta es útil porque te ayuda a calibrar que en este paciente tú tienes un score de 11,6 y podrás evaluarlo al cabo de un tiempo para saber si te ha mejorado con el tratamiento donde estás. Y esto también nos debe ayudar a entender los resultados de los estudios clínicos, porque no es lo mismo un paciente con un campo de cancerización más grave o menos grave. 4 pinceladas de prevención, porque vamos a hablar de tratamiento con Marcus enseguida, y deciros que en prevención, bueno, sabemos todo esto, los dermatólogos lo sabemos muy bien. Se está especulando también sobre el impacto en cáncer de piel de la luz azul. Esto es muy nuevo y, de hecho, sabemos bien el impacto del ultravioleta B, el ultravioleta A, que es complejo, pero es bien conocido. Y con la luz azul yo creo que es muy interesante entender que nuestros queratinocitos tienen ritmos circadianos, por ejemplo. Los que estáis ahora mirando el móvil, si lo estáis haciendo por la noche con luz azul, estáis comunicando a vuestra piel que el tiempo de reparación, que es nocturno de nuestros queratinocitos, por la mañana, durante la luz del día, nuestra piel tiene un ritmo de protección, intenta evitar el daño del ultravioleta. Mientras que por la noche, todas nuestras células y las de la piel también entran en un ritmo en modo reparación del estrés oxidativo, etcétera, etcétera. Pues bueno, sabemos que si estamos expuestos a luz con estas frecuencias por la noche, cuando deberíamos estar durmiendo, esto interfiere en los ritmos circadianos. Y sabemos que la luz azul impide hasta el 50% del mecanismo de reparación de estrés oxidativo de nuestras células durante la noche, y esto no lo vemos. O sea, es muy interesante. No está muy claro el impacto directo en campo de cancerización, en cáncer de piel de la luz azul, pero protegerlo sabemos que mejora pues la pigmentación, el daño solar con envejecimiento cutáneo y posiblemente influye también de forma compleja en lo que os contaba. Las cadenas de reparación del daño que sufre nuestra piel por la radiación ultravioleta es complejo, ¿eh? Y hay muchas interacciones. Por esto, las innovaciones, por ejemplo, en protección solar, ahora están incluyendo conceptos como barreras, ¿no?, reparación o evitar el daño directo en el DNA, pero también favorecer la reparación de este estrés oxidativo o mejorar algo muy importante, que es los mecanismos inflamatorios que inducen también cáncer. Por eso hay combinaciones en el mercado de protectores solares que incluyen una serie de productos con mayor o menor evidencia científica, pero que en cualquier caso son interesantes, porque esto es complejo, ¿no? Y deciros que, bueno, es evidente que hay que recomendar a los pacientes protección solar. Y en estos pacientes, protección solar todo el año, ¿no? ¿Por qué? Porque en campo de cancerización esto sabemos que mejora y previene la aparición de cáncer cutáneo y de queratosis actínicas, y esto está en las guías clínicas. Nos encantaría tener más estudios clínicos randomizados, pero en este caso los tenemos. La protección solar física y con productos de protección solar previene el desarrollo de cáncer cutáneo y de campo de cancerización y queratosis actínicas. Deciros que, en este caso, hay algunos de estos productos que incorporan moléculas de amplio espectro que están favoreciendo la protección a la luz azul, que yo creo que puede ser interesante no solo para prevenir la pigmentación en fototipos oscuros, etcétera, etcétera, que esto lo sabemos, sino en el futuro para mejorar la protección de nuestros pacientes. Y ya para terminar y pasar enseguida a hablaros de tratamiento, deciros que las conclusiones, bueno, ya lo habéis visto, cuidado con las queratosis actínicas, porque no es imposible meter la pata, ¿eh? Incluso intentando ser prudentes. Y lo de aplicar una crioterapia es muy tentador y muy fácil, ¿eh? Pero tenéis que saber que a veces es mejor esperar y tomar una biopsia de estas lesiones. Hay que tratar el campo de cancerización, no nos cabe duda, ¿eh? Porque esto favorece el resultado de lo que vamos a tener. Y pienso que vamos a tener que intentar predecir mejor cuáles de estas lesiones van a responder a los tratamientos y cuáles es mejor tratarlas de una forma más agresiva, incluso con cirugía. Pero por el momento no lo sabemos. Hay algunos síntomas, el dolor, la extensión, la inflamación. Si no ha respondido previamente a los tratamientos, no debemos insistir. Muchas veces, vuelva a aplicárselo, vamos a poner... No, a veces hay que pensar, esto ya es un carcinoma, que no responde. Y prevención con las medidas que ya conocemos, que yo creo que deben incidirse mucho más en protección física, evitar las exposiciones de riesgo y además todo lo demás, que son, por ejemplo, los filtros solares. Y con esto, Marcos, I invite you to start with your time. So Marcos will give the lecture in English. We don't have simultaneous translation, but we will make it easier. So Marcos, please.
Thank you.
Thank you. I hope you followed my lecture a bit.
Yeah, a few things. I could have Fresa, I understood.
Thank you.
And yeah, thank you, Joseph, for this kind introduction. And ladies and gentlemen, it's my pleasure to speak to you for treatment strategies of actinic keratosis. And I apologize, my Spanish is unfortunately not good enough to talk to you in Spanish here, but that's why we agreed to switch to English, and later on maybe we can have the discussion in English or maybe in a blended English-Spanish fashion. And so I tried in this talk, I tried to give you a European, but also, of course, a German perspective for the treatment of actinic keratosis. And we have numerous treatment approaches for AK. I'm sure in Spain you will have numerous approaches too, and therefore it's important to really select or to really find an individualized, a personalized treatment for each patient. And here I highlighted some of the factors or the key parameters which I usually consider in my treatment decision, and Joseph just just showed to us that we are increasingly able to better characterize the lesions, not only by biopsy, but also by non-invasive imaging techniques. For instance, the basal proliferation pattern seems to really correlate well also with the progression risk to invasive squamous cell carcinoma. So for me, that's really a risk factor, which we increasingly acknowledge also as such. And also we know that there are, of course, patient-specific factors, and a major risk factor is immunosuppression. And here, of course, we have to talk about treatment strategies, which are also at the same time, of course, prevention strategies. And treatment options are numerous. We have many ablative approaches, we have surgical approaches, we have a bunch of topical drug-mediated approaches, and then also we have numerous combinations thereof, and that even increases the numbers of treatment combinations and treatment modalities which we could offer to the patients. But when we compare, for instance, the topical treatment approaches, and here we performed an indirect meta-analytic approach to cross-compare different treatment approaches for topicals, which are relevant in the European market. You can clearly see that there is an efficacy spectrum, I would call. You cannot say one intervention is better than the other. Each intervention has pros and cons. But you can say, when you regard the lesion clearance that you can see here, that there are interventions which indeed offer a better or higher lesion clearance. And here, the 5-FU containing topicals are, of course, in this upper spectrum of lesion clearance, and also procedural therapy such as photodynamic therapy is also in this range. And in Germany, we published evidence-based guideline a few years ago, and it was recently was updated almost 3 years ago now, so the next update has to be made soon. And then we have the European guideline, which is very similar to the German guideline, and it was published in 2024. And the European guideline has two key recommendations or two key findings. First, it defines actinic keratosis as a field disease. So we should not only focus on isolated or treating on isolated lesions, so we should really understand and also understand the concept of field cancerization and treat the field. And that's why the guideline also highlights the importance of field-directed treatments and over purely ablative approaches, I would say. And one key element of the guideline is that it was able, at the first time on a guideline level, to provide an algorithm that you can see here. The German guideline, for instance, was not able to provide an algorithm on an evidence-based level, but the European guideline has one, and I think it's very useful for clinical practice and also for treatment decision and clinical decision-making. And the guideline is a little bit complex, but I will try to guide you through this guideline and try to guide you through this algorithm with patient examples. And we should also not forget that the efficacy of any given intervention really depends on the treatment size and on the field size, and really depends on the clinical manifestation. So let's say for a small field, for instance, 25 square centimeters, it's much easier to gain a complete clearance or to achieve a complete clearance of all lesions that we can find in this field. However, when we are dealing with larger fields, for instance, a scalp is 100 to 150 or even 200 square centimeters, we found many more lesions, and here it's much more difficult to really achieve a complete clearance of the entire field and of all the lesions. And likewise, the risk of progression to squamous cell carcinoma is also increasing with the size of the treatment field. And that's why the size of the field is also, to me, a risk factor for the progression of squamous cell carcinoma. And when we have a big or a large treatment field, we should really try to select one of the treatment approaches which lies on the upper spectrum of this efficacy, of this lesion clearance that I just showed to you. And here I have a patient whom I followed up in melanoma surveillance, and he had, I would say, mild to moderate disease on the scalp. We see a few isolated lesions, slightly hyperkeratotic, and for those patients, I think we are in this area of the algorithm. So we have single lesions, some of them may be hyperkeratotic, and for those patients, we may not even need the interventions with a high efficacy or a high lesion clearance. So for those patients, it may be advisable to choose a treatment which is in the medium area of lesion clearance, but also has a good tolerability, because we know that AK is a chronic condition and many patients will need more and more treatments in the disease course, and therefore we should really try to make sure that the patient have a high willingness to retreat their condition. And that's why here, for instance, I treated this patient with tirbanibulin, and 6 weeks after treatment, we have a decent response, almost a complete clinical response of all the lesions. And for tirbanibulin, there was a nice real-world study which was published by an Italian group, and they gathered a big sample size of 215 patients, and they treated all Olsen grades, also hyperkeratotic lesions, which are not in the label of tirbanibulin, and also they treated lesions on the trunk and on the extremity. And here they observed very high clearance rates of wide beyond 80%. And importantly, they also highlighted that the lesions which are located on the trunk and limbs, and also the hyperkeratotic lesions that you can see in the middle here, they showed a decent clearance. So that's why I think this study is very important. And for tirbanibulin, many real-world evidence studies have been published in the last 2 years. We were also involved with 2 German studies, and here you can see that the lesion clearance varies at some point, but the big advantage of tirbanibulin is that it's very well tolerated and the local side effects are really mild in many cases, so we don't really see severe side effects. However, a treatment such as tirbanibulin may not be sufficient in patients with more severe disease or with a larger field. And that's why I think disease severity should also be an important parameter in finding the right treatment for a patient. So for severe patients, I think we really have to choose an intervention which is on the upper efficacy spectrum that I showed to you. And here, just to give you an example, I treated a 81-year-old male who had, I would say, moderate disease. We have widespread disease on the scalp, crusted lesions. We also have hyperpigmentation or dyspigmentation as a sign of chronic actinic damage. And here I treated the patient with 5-FU 4% cream. And I think it's a good treatment success. I would say like maybe a partial response. There are still a few mild lesions, but the condition has significantly improved. And in such a patient, it's much harder to achieve a complete clearance than in the one that I just showed to you, whom I treated with tirbanibulin. And for those patients, we are here in this middle area of this treatment algorithm. And here in this middle area, we have many different treatment options. Also, we have combinations. We find procedural treatments such as photodynamic therapy. And importantly, the European guideline makes a grading of the topical treatments. So it gives the highest grade of recommendation for the 5-FU containing agents, 5% and also 4%. And it gives the highest grade of recommendation for photodynamic therapy, while imiquimod and also tirbanibulin have an intermediate grade of recommendation. So there's a grading, and I think this really reflects to the higher efficacy or the higher lesional clearance of the 5-FU containing agents. And so for those patients, we really are, we are really good at selecting interventions which are at the upper end of the spectrum of this, of this efficacy. However, when we choose those agents or those interventions, also photodynamic therapy, and we can maybe later on also discuss if photodynamic therapy is performed in Spain. In Germany it is, but it's not covered by the statutory health insurance. And we know that for those agents, usually we have more severe local side effects. And that's why we always say, okay, if there is no pain, we don't have any gain. And here you can see a patient whom I treated with 5-FU, and after 3 weeks, he developed moderate to severe exfoliative dermatitis, and also a patient whom I treated with conventional, that is a red light photodynamic therapy, who has the severe local side effects. And the good thing is that when we observe those side effects, we can always tell the patients that the results will be great not only regarding lesion clearance, but also regarding the cosmetic appearance of the lesions, right? But still, I think for those patients, the no pain, no gain statement holds true. And as the European guideline makes the highest grade of recommendation for the 5-FU containing agents, I would like to go through some of the study trials that have been published for 5-FU. 5-FU acts as a pyrimidine analog, and it's available in different concentrations. Or in Germany, it's available as a 4% cream, which is to be applied once daily over 4 weeks. And then we have a 5% cream, which is to be applied twice daily. So it's a little bit more complex, the schedule. And both concentrations were compared in a good trial, which was published 2016. And it was a 3-arm trial comparing 5-FU 5% and 4% versus vehicle. And here you can see that the efficacy regarding lesional clearance is almost similar in the 4% and the 5% creams. However, the tolerability profile and the incidence of severe side effects was much less pronounced and much less common in the 4% cream. And that's why, to me, the 4% cream offers actually many more advantages than the 5% cream. So in Germany, I only prescribe the 4% cream because I don't see any advantage of the 5% cream anymore. And but still, for the 4% cream formulation, still we observe moderate, sometimes also severe local skin reactions, and they peak, let's say, after 3 to 4 weeks on treatment. And we also know that subclinical lesions may become more evident or may become more manifest, which we also observed for the imiquimod formulations. So in the beginning, the patients may experience or they may be concerned that their condition gets worse. But then after the local skin reactions subside, usually the patients have a very good treatment response. And we also know that the local side reactions, there's a correlation between local side reactions and the likelihood of achieving a complete response. So here we performed a subgroup analysis based on the pivotal trials, and here we could observe that there was a significant correlation between the occurrence of many side effects, but most importantly of severe erythema, and achieving a clearance rate of more than 75% of the actinic keratosis. That is a partial response. So we can tell patients, if you experience local side effects which are severe, you can be lucky because the side effects, they will subside by themselves, and then you will be even more likely to achieve a good response to the treatment. But also we know that the side effects also increase with the number of actinic keratosis lesions which we observe at baseline. And that's why I think we should always try to not induce too much of side effects, because I told you we need to have this willingness to retreat, in particular in naive patients who have the first treatment. We should not, by inducing side effects, discourage them from undergoing future treatments. So that's why I think we really have to find the ideal treatment time point when to start a treatment. So we don't want to wait until we have squamous cell carcinoma or too many lesions, but what treatment time point is the best one, or what treatment time is the earliest one which we should aim for. And maybe we can also discuss this later on in our dialogue. And now what to do. I showed to you real-world data for tirbanibulin, and also real-world data for 5-FU were published in the last 2 years, and there was good publication from the Italian group, which is very active in this field, and they also performed a real-world study on patients with 5-FU 4%, and here you can see that the efficacy measured here by an IGI score rating semi-quantitatively, the response was almost completely improved or significantly improved in the vast majority of the patients. Again, highlighting the very good efficacy of 5-FU. But at the same time, the study kind of confirmed what we saw in the pivotal trials, namely that we have side effects which may be moderate in up to 20 to 50% of the patients. And now what to do with side effects? How should we handle side effects? And here, I think the intended treatment period for 5-FU 4% cream is a 4-week period. However, everybody who uses 5-FU 4% knows that treatment or side effects will appear after, let's say, 2 to 3 weeks. And then when you stop the treatment response is largely maintained. And we observed this here in a post-hoc analysis also of the pivotal trials. And here you can see that the once daily 2-week application dropped from 80 to 60% of complete clearance, and then from 100% partial clearance to 85% in a 2-week application period. So I would say even though the 4-week application is the intended period, we should still try to at least have the patients 2 weeks on treatment with 5-FU 4%. After that period, I would say, okay, we are good to just stop the treatment and wait until the response or reevaluate the response in 3 months or so. But we should really try to aim at this 2-week treatment period at the very least. And then how to handle local skin reactions which arise in treatment with 5-FU. And here also the Italian group performed a Delphi consensus survey and many European experts which are heavily involved in the treatment of actinic keratosis. And they made a consensus of 11 recommendations for a standardized management of side reactions arising on 5-FU therapy. And here I highlighted the key recommendations of this Delphi panel. Here you can see that the sample from the experts. And here are, to me, the most important recommendations. So when we have severe local side reactions, treatment should be paused for a few days. So we can also prescribe emollients. However, in my experience, emollients don't really help. So the side effects subside usually by themselves. So just waiting and being patient usually is the best treatment for the side effects. Likewise, the use of steroids is actively not recommended to alleviate the local skin reactions. Usually we don't really need local steroids, but sometimes I know many colleagues who prescribe them. And then this approach controls the reaction while maintaining optimal treatment results. And I told you that, in my opinion, it's ideal to keep the patients on treatment for at least 2 weeks. And with that, I would like to end my part of treatment. It was a little bit a German perspective, but I think also a European perspective. And thank you very much for your attention. I'm very much looking forward to this cross-border discussion and to the cross-border questions. Thank you.
Okay, thank you. Marcus, if you can come here, please. Muy bien. Preguntas, comentarios. Bueno, yo os voy a preguntar algunas cosas. ¿Quién utiliza crioterapia para tratar pacientes con queratosis actínicas? Levanten la mano. Vale. Do you use cryotherapy? I use cryotherapy, and so it's interesting. So a few weeks I was invited to give a talk in Switzerland, and there I learned that cryosurgery or cryotherapy is the treatment method of choice for actinic keratosis because it's very well reimbursed in Switzerland. And this really highlights that, for instance, or in particular, the procedural therapies or the ablative therapies are really driven by reimbursement issues and regulatory issues. So it's offered what is paid for in the practice.
And this makes a difference in terms of what treatments are used in several countries or otherwise. In the US, they don't want to have follow-up visits because they are not paid for that, so they don't like patients coming to you with irritation, things like this, or reimbursement issues. We have in Spain situations sometimes a bit strange. So we have in ambulatory clinics nurses doing cryotherapy of sepsis or maybe this, without much knowledge about diagnostics, and this happens to be the case, so it's crazy. And GPs can also use cryotherapy, but we need to know. So cryotherapy on the nose with these lesions, don't use it there, because you can misdiagnose the skin cancer with this.
Yeah.
So it's the clinical value of this. Do you treat patients first when you presume to have a lot of irritations because the patients have a very advanced stage with field cancerization? Do you treat the patients in different times and not the whole thing in one shot? What do you?
Yeah, so when I started, I tried to kind of make a sequential approach and to do it by anatomic area. Let's say left side of the face, and then right side of the face, and then scalp. And so with more time, I usually, when I see a patient with widespread disease or widespread field cancerization, I try to do the whole field, right? So there's one treatment.
Yeah.
And then usually, as I said, so usually I try to choose one of the upper or one of the more efficacious interventions. Of course, I educate the patients that there will be side effects, and then I usually wait, let's say, 10 to 12 weeks, and then I'm going to evaluate what is left over. And for the treatment-resistant lesions, I usually focus on them, and then I will do biopsies or maybe also imaging techniques, because the treatment-resistant lesions are either the high-risk lesions, which have a higher likelihood of progressing into squamous cell carcinoma, or they have a higher likelihood of being misdiagnosed and not being actinic keratosis. So maybe it's a basal cell carcinoma or a squamous cell carcinoma. And this approach, I think, is it's time saving also.
Do you see, how often do you have the follow? ¿Cuántas veces veis estos pacientes al año? Una vez al año, que levanten la mano, más o menos, la mayoría de veces.
Yeah.
2 veces al año. 3 veces al año, bueno, depende, ¿no? De lo que podamos hacer y de lo que vemos, ¿no? Claro. So how often do you see the patients? No, it's challenging, because this is for the whole lifetime that you have probably to see the patients at the end, and this is very difficult for health systems to keep going. Okay, so and for that we have this challenge. Do you have phone calls from patients to have a follow-up during the 1 month treatment with 5FU, or how do you keep the patients engaged? Because compliance is also an issue for patients too in 1 month. Huh?
It is. So usually my approach is I try to see the patients after 12 weeks to evaluate their response. If I see treatment-resistant lesions, usually I repeat the same treatment for one time. And then after that, I reevaluate again after 10 to 12 weeks. And if I still see resistant lesions, I either do a biopsy or I switch to a different treatment modality, right?
Yeah.
And so also, Joseph, maybe I can ask you a question. We are increasingly able to better characterize the lesions also with the non-invasive imaging techniques.
Yeah.
The downside is that those imaging techniques are also time-consuming. And so I was wondering, in such a common conditions as actinic keratosis, we all have numerous patients of actinic keratosis, and in such a common condition, how do you select the patients for the non-invasive imaging techniques? Do you offer it to everybody who can pay for it, or do you offer it for the academically interesting patients, or how do you prioritize?
Yeah, absolutely. So I have to say that many dermatologists don't take photos of their patients, so please take photos, and the photos can help you in monitoring and understanding what happens from the baseline to the follow-up visits, and they have to be good photos, because if not, you don't know where you are after 6 months and if the lesion was responding or it's a different lesion or whatever. So take photos, and this is cheap procedure. So let's start with documentation, clinical documentation. If you are able to use polarized light photography, it's much better, because you saw that some of the photos are bright because for obvious reasons. With polarized, it's much easier. So this is easy. But of course, if I was showing you LCOCTs, confocal microscopy, and this is only available in academic centers in most cases in Spain, a few of them, and we use this in diagnostics of very specific patients in the hospital with organ transplant or immunosuppressive treatments or whatever, when we can. But we cannot have this in every patient with these situations. We are trying to help understanding which lesions correlate with this aggressive histology with some clinical clues that maybe will help, or dermoscopy, that is what everybody knows how to do. But at the time it's not available. So this is the challenge. Maybe in the future we'll have an LCOCT pocket in your cellular and you can do these things, but it won't be the case today. And the device are expensive, very good for research, in some patients very good for management of patients, so taking decisions. I have to consider surgery here or margins in surgeries. We use this all the time in complex patients, but not in every case.
Yeah, and I think, as I said, so actinic keratosis is such a common disease, it's such a common decision. But I think in Germany we have the same situation. We have the techniques available in the larger academic centers, but in the dermatology practices, they are not there yet. And I would wish that we will have a broader access to those techniques for more of our patients.
Absolutely.
And so maybe I can ask you one last question on prevention. So you said, or you showed to us that sunscreen, of course, is a very important basic measure. How do you treat OTRs or immunosuppressed patients, or what do you think of systemic chemo prevention? Does it have any value for you?
In some patients with multiple SCCs, we consider retinoids and other options, but we know that this is not so good for many reasons. And clearly, it's a challenge group of patients because the tumors are very aggressive all the time. They come with new lesions in every follow-up, so we have to keep going a very intensive follow-up with these people. Not every patient submitted to immunosuppression has the same considerations because we know that different levels of complexity or risk are depending on the type of immunosuppression, how the patients have their basal, at the time of baseline, their problem. So patients with many lesions, we try to treat the patients from the very beginning and not wait for the skin cancer to come. We try to educate nurses and specialties involved in this patient's kidney, and other organs, because they can help in identify which patients or in which situations they have to send the patients to the dermatology clinic. It's very important. And why not the dermatology services with them can help as well. So we can improve with not evolving into very expensive procedures, but we are limited with the time. So in a hospital, we have many patients, new patients every year, and prevalent patients during many years. And we cannot see them, all of them, in dermatology. It's impossible. So, but sunscreens are useful, but physical photoprotection is very relevant as well. So use hats if you don't have much hair, and even just
sleep a lot. That's what I learned from you.
And I have to say that just with a good ointment, you improve many times the quality of life of these people. So sunscreens can be complementary at the end. So if we don't have any other questions, tenemos que terminar ahora. Y muchas gracias por la atención. And thank you, Marcus. It was excellent. Thank you. Bye-bye. Y creo que hay que continuar. Hay un coffee break. Creo que ahora...